Thank you very much for the invitation. It's really an honor to come back to Taiwan. I've been here many times and always enjoy the discussions and the interactions, and I learn very much from my colleagues here in Taiwan. So it's an honor, and I hope I can become an honorary member of the Maple Prostate Club. I'm not part of any prostate club, so this would be the first. So thank you. So just to show you, we just built our new hospital. We moved in. There's just one section left to build, but this is where we are now. This is the biggest building now in Montreal, the biggest building in the province of Quebec. So this is a $4 billion project that we built, this hospital. It's 3 university hospitals that are the University of Montreal hospital centers that were fused into one. And we have the research center is here, and we have the cyclotron on beneath, so we do our own PSMA, and we have about 40,000 employees working here. And this is the largest building now in Montreal. And this is the University of Montreal on top of Mount Royal. For the urologist, it looks like a big penis sticking out of Montreal. It's the tallest on top of Mount Royal, which is the only mountain in Montreal. It's a French architect, and we are very happy that we are in the top 100 universities in the world now. So these are my disclosures. I work with many companies developing clinical trials and helping to consult on different issues, and the hospital and the research center receives the funding for all the research we do. So let's get into the topic here. So this is the clinical states model of prostate cancer that everybody now is aware of. We won't discuss today locally or localized prostate cancer or locally advanced, which is a lot of patients that are screened that we might not even need to treat. And this is a whole different topic about the role of active surveillance and how to treat the locally advanced disease. But really, what we worry about the most is this state of the disease, the mCRPC state, because until patients are mCRPC, you do not die of prostate cancer. That is the simple reality. The only patients who die of prostate cancer are mCRPC. All the other patients die with prostate cancer and not because of prostate cancer. So really I think the goal now that we have, many of us working in the field, is yes, we need to do more in terms of finding new treatments for mCRPC, but ultimately what we would like is that we don't even reach the state of mCRPC, and that patients avoid mCRPC and die of other causes before reaching the state of mCRPC. Because you don't only die from mCRPC, it really is the only state that you suffer from the consequences of prostate cancer. The metastatic consequences and all the other issues really occur all in the mCRPC state. So this is a philosophy that we want to make prostate cancer a chronic disease where we will die of something else and not of prostate cancer. Because everybody in this room is going to die one day. Us in this prostate club, we would prefer it's not because of prostate cancer and because of some other cause that somebody else is not able to treat. So we have developed many treatments, and I am very happy that I was involved in almost all of the clinical trials now that we have approved drugs for mCRPC. So the question that I was asked is to address the evidence of earlier treatment to improve outcome. And so let's go back to the first trial the first drug in mCRPC that was hormonally based, and that was abiraterone. And this is the pre-chemo study, and I came here when you had the launch in the pre-chemo setting, and it was very impressive that we had progression-free survivals of 16.5 months with abiraterone and prednisone. Does anybody remember progression-free survival with chemotherapy? Anybody remember? It was about 6 months. So when we talk about progression-free survival, and it's probably unfair to compare, But in all the chemotherapy studies, we're talking about somewhere around 6 months for progression-free survival. So when we saw 16.5 months progression-free survival, I think we were all very impressed. And then when we saw median survivals of almost 3 years, we were also very impressed, because anybody remember the trials with chemotherapy median survival? It was about 19 months. Yes, more symptomatic patients later in the disease, but even the most recent study with docetaxel, comparing it to cabazitaxel, where many patients had low PSA, no symptoms, median survival was only 2 years. So if we talk about sequence, I think it's a better sequence to go hormonal than chemotherapy, because in that clinical trial, when patients failed docetaxel, they had abiraterone and enzalutamide in the post-chemo setting, and patients still only lived 2 years. And the other thing is, the placebo arm lived 30 months. Why did the placebo arm live so long? Well, because 61% got docetaxel, 44% got abiraterone in the placebo arm. So that's why they lived so long. They would never live 30 months on a placebo. So it's important when we look at the survival difference to realize that the placebo arm was very well treated. In Canada, less than 50% of men get chemotherapy before they die of prostate cancer. So these patients in the placebo arm were treated better than the average man in Canada. Just to keep in mind, I don't know what the reality here in Taiwan, but many men either refuse chemotherapy or are not well enough to get chemotherapy, or don't believe it's worth the benefit of the risks with chemotherapy. So, some other evidence, and I think if you've heard me speak, this is something I keep repeating, but when we look at who benefits the most from a drug like abiraterone, you realize that the ones that benefit the most are the ones with no pain. See, this is the ones driving the survival advantage. If you have just minimal pain, you're getting less advantage. If you have lower PSA, you're getting more advantage. If you have lower alkaline phosphatase, you're having more advantage. So really, 3 of the best predictors of how quickly you will die, the ones who you start abiraterone earlier have more of an advantage in overall survival. And when you look at just strictly PSA, and I was reassured, I heard that here many men get a drug like abiraterone even below PSA of 20, which is excellent, because in many places people wait for all sorts of reasons. But what we see here is that if the PSA was less than 15 in the clinical trial, the median survival was a reduction in death of 47% compared to patients with PSA over 100. So the earlier you start, the more advantage in overall survival. This is not lead time bias. It's really compared to starting later. So the earlier you start PSA, the better the impact in terms of overall survival. And again, when you combine pain and PSA, if patients have low pain or no pain at all with low PSA, the median survival was 4.5 years with abiraterone. That's extraordinary for MCRPC. And if you start with pain and a higher PSA, the median survival was 31 months. The difference is 1 year advantage in overall survival when you start early versus 3 months when you start later. 3 months is still statistically significant, but for the patient, I would rather have an extra year of life than an extra 3 months. So why would starting earlier be more effective? Can I ask the Prostate Club why the hormonal therapy would be more effective earlier than later? Exactly. So I think the longer you wait, the more hormone-insensitive clones will develop. And so your hormonally based therapy will not work as long and will not be able to be as effective. Chemotherapy is not the same. Chemotherapy, whether you start earlier or later, when you look at the forest plots, it's the same benefit because it's going to act on the hormone insensitive cells. But for hormonally based therapy, the earlier you start, the more effect and the longer the effect is going to last. And this is, I'm part of the St. consensus, or the APCCC, and here only 8% would give chemotherapy as first line for patients with MCRPC. And that number is even shrinking as we progress. Very few patients now would get chemotherapy as first line for MCRPC, and I think is what you're doing here. Do I still give chemotherapy first line? Yes. In some patients, I will still give chemotherapy first line for MCRPC. The patients I worry about are patients with a high burden of metastatic disease with low PSA. I think is a reflection of the androgen receptor not being very predominant in that cancer. So if you have a PSA of 10 and patient has 20 bone metastases plus multiple lymph node metastases, something doesn't work. It isn't proportional. So I would tend to at least consider chemotherapy. Patients who have high visceral metastases, especially liver, if you biopsy them, many of those metastases are poorly differentiated, and those patients I will at least discuss starting with chemotherapy and then keeping the hormonals. And patients with very severe symptoms, very pain, high doses of morphine, my impression is when we need very fast pain relief, we get faster relief with chemotherapy. But patients, fortunately, are coming in more rarely with severe symptoms. This represents less than 10% of my patients coming for MCRPC. So yes, I think there is still a role for upfront chemotherapy, but in select patients. So if we go now, this is MCRPC. So what can we do to try to delay MCRPC? Well, obviously we can target the MCSPC or MHSPC, call it as whatever you want, but these are patients that are still metastatic but still hormone sensitive. So this is probably some of the best natural history data of patients starting on ADT alone for metastatic prostate cancer. This is from Stampede. So how quickly does the average patient become castration resistant if they are MCSPC and you start ADT? So you have it here. 11 months, less than 1 year, is the average patient becomes MCRPC. So you go from MHSPC, you do ADT alone, the majority will be within 1 year already castrate resistant. We used to think it was 2 years, but in reality, when you do it in a clinical trial following patients properly, it's less than 1 year. And look at the median survivals in an era where we have chemotherapy for castration resistant. We had abiraterone for castration resistant in the Stampede trial. 3.5 years survival. This is all comers, not only high risk or high volume. This is terrible. When I was a resident 30 years ago, it was 3 years. So we only increased survival by less than 6 months in 30 years. It's disastrous. So what that tells me is that we have to be much more aggressive for patients who are MHSPC. And that was the basis of all the clinical trials that were done. So the other question that comes up, if you give ADT alone, can we predict outcome? The answer is yes. And everybody knows the best predictor, when a patient comes in and he has 250 of PSA, and he tells me, how long do I have to live? I tell them, give me about 6 months, I'll tell you. It depends on their PSA nadir. So this is from the SWOG study. This for me is a pivotal study. So if the PSA So sometimes it goes from 250 down to 2, and the patient is jumping with joy. Me, I am very, very worried, because 250 down to 2 looks very good, but in fact is not so good. If you stay above 4, median survival was 13 months. So 250 down to 5 looks very good, but it's really very bad. Those patients, if you don't follow them closely, you will see they will be MCRPC within less than 6 months. So a patient who doesn't go below 4, the next time you check the PSA, he's likely to be already progressing. So these patients do very, very bad. If patients go between 0.2 and 4, median survival is 44 months. The best patients are patients who go below 0.2, median survival 75 months. So this has become, when I was chair of NCIC, the NCI of Canada, we had a think tank how we should design clinical trials. And this is our new objective for clinical trials, is how many patients we can get to go below 0.2, becoming our surrogate for effective therapy. So 0.2, keep that in mind, because this is what we are going to need to look at when we start deciding intensifying therapy. So can we do something more than ADT alone? Naturally, we need to, because even 75 months for somebody who is 60 years old means they're going to die around 65, 66. Still not enough. So docetaxel, you know the results. This is the updated results that was published last year. The median survival advantage is around 10 months. And look at the curves, how they go with time. They come together, okay? So what you need to look at, we talked about 0.2. Look at, in a recent study, what % of patients get to 0.2 at 6 months with ADT alone? Only 14%. This is all comers, not only the high volume. This is everybody in the study. Only 14% get to 0.2. You add chemotherapy, you go about 27% get to 0.2. So we need to do even better than chemotherapy, but it's already at least doubling the number of patients we get to. And this is probably what's driving the survival advantage, is the % of patients we're able to get to very low levels. But who benefits really from the chemotherapy? It's only the high volume. The most recent analysis, almost 17 months improvement, 0 months for the low volume patient. So, slide won't change. So if we look now at latitude with abiraterone, I think you know this data very well because you have abiraterone for a long time. We've been talking about this data for a long time. But this is the data that was published in New England Journal in 2017. This is the first analysis, and things to look at. Obviously, we know survival advantage, 38% improvement or reduction in the risk of death with abiraterone. But look at the survival of the placebo arm. 3 years from diagnosis to death is terrible. These are high-risk patients. Even though they had access to something else, if they didn't start abiraterone up front, they died within 3 years. But look at the curves. Look at how they look, how they keep separating, and how they're not coming together. So the effect seems to maintain over time. Progression-free survival, 50% reduction, that's clear. This is the latest analysis published this year, and I wrote the editorial in the Lancet to accompany the article. And when you look at this, now with 52 months of follow-up, median overall survival advantage, almost 17 months. Again, look at these curves. The patients treated in the placebo arm are not catching up to those who got abiraterone up front. And that survival advantage is maintaining even at the very long term. So I think the patients are really benefiting from early, intense therapy, at least for the high-risk population. And the survival of the ADT is the same, 3 years survival. If you start with ADT but had other treatment after, it's already too late. And we're coming back to the heterogeneity. If you start with ADT alone and you wait for CRPC, you develop clones that are less responsive to chemo, to hormonal. You need to start really as early as possible in these high-risk patients. And what you notice here, and this is just to show you that every other secondary endpoint was statistically significant, delaying pain, skeletal-related events, chemotherapy. But look at how quickly they became CRPC. 7 months. I told you it was about 11 months, all-comer. If you look at just high risk, in 7 months. So I'm hearing that you're having trouble convincing your government to pay for hormone sensitive. And I'm telling you, just tell them it's only 7 months more of therapy to get that benefit. Because in reality, they are going to be MCRPC within a median of 7 months. And then it's already okay to give it. So you have a choice. You give it 7 months earlier and you get a much bigger advantage in overall survival. It's really only 7 months of extra therapy. And when I wrote my editorial in Nature, I said, when you look at all the studies together of whether it's abiraterone, apalutamide, enzalutamide, basically you're getting an extra year of life for about an extra year of therapy. That's the best cost-benefit ratio I've seen in cancer for a long time. And Nature published exactly as I wrote it, so they agreed that that made sense as a way of looking at this data. Over and above for the abiraterone in the hormone sensitive is that you're improving quality of life in the patients. You're improving pain scores. And what's nice is when you have another phase 3 study saying exactly the same thing. So Stampede for chemo said the same thing, and you see the curves as they come together, and look at the curves for abiraterone as they continue to separate. So they're showing the same thing, same survival advantage. Instead of 38% reduction with latitude, it was 39%. So the same, and 27% risk reduction in death with docetaxel. So, at least preliminary analysis looks like survivals are pretty much the same whether you start with chemo or docetaxel. But clearly, I think over the long term, and we've done many analyses that we've published, abiraterone looks like it's going to be more effective than chemotherapy on the long run in terms of improving survival. And I think it's because of these curves that don't come together when you talk about progression-free. And over and above that is that you remain free of MCRPC for much longer when you start with a hormonally based therapy than with chemotherapy. So what about low volume, low risk? I think this is where, for me, high risk, high volume, you need to do something more than ADT. I think it's unethical, or you almost have to justify why you don't do anything more than ADT. This is more, I think, where we need to personalize, is the low risk, low volume patient. I'm not ready to say that everybody should get more than ADT. Here is where we need to do some work as a worldwide organization. But if you look at the Stampede data with abiraterone, you are getting a 34% reduction in the risk of death in the low-risk patient. But you see that the death rate hasn't reached median at 4.5 years. So they die much longer. So already one thing, you need to consider the age and the comorbidity of the patient. If they're going to die of something else within 5 years, you probably don't need to start up front in a low-risk, low-volume patient. But somebody in their 50s or 60s, I think we need to at least consider more than ADT. Look at the high-risk patient. They really need other therapy. So this is overall survival. Look at cancer-specific survival. It's having more of an impact on cancer-specific survival than overall survival. So here, you're a 49% reduction in the risk of cancer-specific death. What does that mean? It means that some patients are actually having time to die of something else. This is the first time we're seeing this in prostate cancer, where there's competing causes of death, even in metastatic disease, because our treatment is so effective. They have time to die of something else, which is, some people would say that's bad. I would say it's good. It means that we're controlling the disease and patients are living longer. So if we look at our survival advantages for mCRPC, pretty modest, 3-4 months. Then when we get to HSPC, now you're up to 16.5 months improvement in overall survival. Same drug, just given earlier. So the guidelines around the world now recommend either chemotherapy or abiraterone for hormone sensitive. So let's finish with non-metastatic CRPC. I know that this is something that's coming, or you already have approval? No? Yes, you already have approval. Okay. We have approval and reimbursement now. So we were able to convince them that this is something that needs to be taken care of. And again, if we treat in this state, we delay reaching mCRPC. So what is non-metastatic CRPC? It's rising PSA with castration, with no evidence of metastases on conventional imaging. Okay? We all agree. These are metastatic patients. The PSA is rising because of something, especially if it's rising fast. But the definition is on conventional. So some people say it doesn't exist because if you do a PSMA, you see something. We all agree. But the definition is based on conventional, which means that it's such low volume disease, you don't see it on conventional imaging. It needs to be managed. So these are the only ones we would consider are a high risk, which are probably very low metastatic disease. From the beginning, I'm telling you that to be more effective, you need to treat earlier. So this is the ideal setting. These are really early metastatic disease that are at high risk of becoming mCRPC and causing death. So targeting the androgen receptor made sense because we did other studies targeting just bone that didn't work. So why apalutamide? I think you know it's a very potent AR inhibitor. This was very elegant work done out of Sloan Kettering by Daniel Rothkopf, where this is FDHT PET, so it's really targeting the androgen receptor, and you see the metastases very well. And you give them apalutamide, and within 4 weeks, this is where I would like to see PSMA go, to help us have early signals of response and resistance to therapeutics. This is where I think we would probably gain a lot of time in figuring out whether this new agent is worth investigating or not. And it would be good in the clinic if we could say we give something and we don't always have to wait 3 months to know if it's working. We can maybe act faster to add or change. So here, within 4 weeks, the target is being hit perfectly. You don't see anything being picked up. And the PSA response was the best we had ever seen with an AR-targeted therapy. So this is the apalutamide in NMCRPC that was published, and I helped co-lead. So the design was very simple. You know it very well. These were all high-risk patients, PSA doubling time of less than 10 months, and we allowed lymph node metastases, which was a bit unique, but we considered metastases only distant, outside of the pelvis. And the primary endpoint was metastases-free survival that around the world was accepted as an endpoint. And this was unique. This trial was the first time that we actually kept patients blinded when they progressed, allowed patients to get any treatment they wanted, but the company actually provided abiraterone, and we waited to see second progression. So we actually took the time to capture second progression, which we did not do in 302 or Prevail or any of the other trials. So this was unique. And why we did this was to get an impression whether the patients on the placebo arm were going to catch up to the patients treated upfront for non-metastatic CRPC. So you know the results very well. This was beyond our expectations. 2 years delaying metastases. And this was significant whether you were over 75 or under 65, whether PSA doubling time was less than or greater than 6 months, which is important because this comes up. Is it worth treating a patient with a doubling time of 8 or 9 months? And whether you had lymph node metastasis or not, they both had an advantage in delaying progression. Survival, the first interim analysis was not reached, but it was very close to being significant. But you have to remember that this arm was very well treated. Within a couple of weeks of becoming metastatic, they had subsequent treatment. So it was impossible to see a difference in overall survival this early. We did not even expect to see a separation of the curves this early, because this patient population was treated for oligometastatic CRPC. The majority only had one metastasis, low PSAs, so treated much earlier than the 302 study that we talked about. So what this tells us is that even though these patients were treated very early in the metastatic state, they don't do as well as the patients getting upfront apalutamide. So the PFS2. This is the attempt to see, do the placebo arm catch up to the apalutamide arm? Okay? Because if treating low volume metastatic CRPC was just as good as treating non-metastatic CRPC, these curves should come together over time. They don't. They continue to separate even with an extra year of follow-up. This was at ASCO GU last year. The curves continue to separate. They do not come together like a banana, because if the treating a little bit later was just as good, the curves should come together over time, and they don't. The other way to look at it is if you start in low-volume metastatic disease, you respond to therapy for 23 months, which is excellent. This is almost twice as long as when you start with real MCRPC like 302 that responded for about 12 to 14 months in terms of PSA. If you start apalutamide upfront in NMCRPC, you respond for over 40 months. So it looks like starting earlier, you have much longer response to therapy. And these are the results of PFS2 that was just presented at ESMO last month. You see the curves continue to separate. So they're not coming together even now that we're at over 50 months of follow-up. And in terms of death, we missed statistical significance. This is still not the final analysis, but we missed it by 7/1000th of a point. Okay, that's really close. We needed to have 0.012. We had 0.019. That's pretty close to being statistically significant, even though the patients in the placebo arm were treated very early. And again, look at the curves. Don't look here because there's only 4 patients and 2 patients, but the curves are continuing to separate in terms of survival. So we don't even, the survival looks like it's going to be positive, even though the placebo arm was treated earlier than the real world setting. The other important point, I think, to prove that earlier makes a difference is look at the response rates with apalutamide. PSA response of 93%. That's the best we've ever seen. And I think it's coming back again. We're treating low volume disease. We're getting very good responses. And look at the response that we're able to get to 0.2. 40% in the CRPC setting. The best we had to date was with enzalutamide with 20% in PREVAIL. More metastases, less undetectable PSA than we're able to read. So complete response in 40% of patients. And why is that important? It helps you to predict time to metastases. If you go below 0.2, at 40 months, you're not even close to the median time to first metastasis. And if you have a 90% decline, it's way beyond 3 or 4 years. So the PSA reduction is very important. The other important aspect that I think we underestimate is how powerful it is to delay resistance by starting earlier. Because we all want our patients to respond as long as possible. So when we give in the NMCRPC space, you see that the response is over 40 months before the PSA starts to progress. And when you look at, again, if you start later, patients develop resistance earlier. So the first one on the left is enzalutamide after docetaxel and after abiraterone. They respond for less than 6 months. If you go to Affirm after docetaxel, they respond for about 8 months with enzalutamide. If you go to Prevail, first line enzalutamide, but after bicalutamide and other antiandrogens, they respond for 11 months before PSA progression. Terrain, really first line, no bicalutamide, but you respond 19 months. And then when you get to NMCRPC and you go to apalutamide, you had a response for over 40 months before PSA progression. So really, the earlier you start, the better the response in terms of developing resistance. And the quality of life is not negatively affected even though these patients are asymptomatic. So all the guidelines now approve apalutamide for high-risk non-metastatic CRPC. In terms, just very quickly, because I know you're going to talk about hormone sensitive, but apalutamide was also tested in the hormone sensitive setting with a risk reduction of radiographic progression of over 50%, which was very impressive. But what was very revealing, and when I wrote the editorial here, is that now we have data in low volume, low risk patients. So Titan and Enzamed also both accepted patients that were not de novo metastatic patients, but patients who progressed, patients who were low volume, low risk, and the results are positive for all the patients, regardless of volume or risk, 33% reduction in the risk of death. So these are the guidelines in Canada that came out summarizing CRPC. It's becoming very difficult to write guidelines now because we always have to say, and look what I wrote under each first line, second line, third line, depending on what they received before. And this is the reality in sequencing, is that now it's not just, and this is a sequencing paper that just came out from the CUA that looks at what we would consider as first line, and then depending on the patient characteristics, second and third line. So these are all accessible, and I'm going to send them to Janssen if you're interested in the guidelines. Actually, the AUA copied our guidelines from the CUA from 2010. We were the first to show disease states. I'm flattered they didn't quote that they were copying ours, but that's okay. And these are the algorithm in terms of sequencing. So, in the past, it was very simple. Patients got ADT and they became MCRPC, and then we did hormonal, then chemo, and all the rest. Now the reality is that they can get APA or ENZA in the non-metastatic CRPC setting. They can get ABI for the non-metastatic HSPC if you look at STAMPEDE. They can get docetaxel, ABI, APA, or ENZA in the patients who are de novo metastatic, and then become MCRPC. So what do we call those patients? They're MCRPC, but they've progressed already on other therapies. So how we're going to treat them is going to depend on what they got prior to becoming an MCRPC. So here, first line MCRPC would be docetaxel if they were already exposed to APA or ENZA, and then it continues as we go down. So the future, I think, as we start progressing first line, second line, third line, is that we're developing more and more genomic abnormalities. In the first line, it's very good because almost every patient responds to hormonal. So we're looking for maybe 5 or 10% of non-responders. But as they go through different lines, this becomes more and more relevant. So now in Canada, we're doing studies like this. We're actually taking circulating free DNA, looking at their mutational status or their genomic profiles, and then trying to link them to drugs that address those actionable targets and trying to see if this is a sensible way of developing future trials. So in conclusion, to treat MCRPC, AR-targeted therapy like abiraterone should be used first line in almost all patients, and earlier seems to be more effective. To actually prevent or delay mCRPC, abiraterone should strongly be considered in addition to ADT in patients with high-risk MHSPC. You can say all patients, but especially in the high-risk patients, and then personalized in the low-risk. Apalutamide is recommended for patients with high-risk non-metastatic CRPC to delay mCRPC, and the future is probably going to be more development of novel treatments and sequencing. We're probably going to be more and more based on genomics. So I had half an hour to talk. I think I'm just about done my time. I purposely didn't talk about PROfound and about CARD, but PROfound is the first phase 3 study, so I helped to co-lead that. So it's very exciting now looking at mutations of homologous repair defects like BRCA2 that we're actually able to predict response. And this is the first example, and there are multiple ones that are going to come, that we're going to eventually start basing our decision, especially beyond the second line on genomics. This is going to help us maybe choose better therapies and avoid waiting too long for patients who are destined to die of the disease. So thank you very much.
Thank you.